Okay. So basically, atrial fibrillation is becoming more and more of an issue when we discuss patients having valvular heart disease and interventions. Currently, it's more applicable for surgical ablation during surgical valves that are being performed, but we know that in percutaneous world there is some impact of atrial fibrillation long-term outcome, and this may be a point of discussion. The decision-making involving atrial fibrillation at the time of surgery is quite complex and based on surgical experience first and foremost. Not only whether to perform the procedure, but also what type of lesion set and technology. And this is a key because one of the most abused terms in the field of atrial fibrillation is MACE procedure. And I can tell you, I proctored cases in over 75 operating rooms in the world, and I'm yet to see a surgeon that actually knew how to do the MACE procedure as was invented by Jim Cox. So that's a big problem. So proctoring is a huge issue here. Patient variables, what's the impact, type of duration and duration of atrial fibrillation, LA size and comorbidities. Those are all very difficult questions because if we add to the complexity of the procedure, we want to make sure that we at least try to contribute to the patient outcome. So we know, I'm not going to teach you medicine, you know it better than I do, most of you guys. Atrial fibrillation is bad, associated with increased all-cause mortality and morbidity, especially with regard to strokes. This is a slide I got from Mark Gilinov showing that basically after mitral valve surgery, patients with no AF are doing worse than patients, doing better than patients with AF, and therefore we should at least look at it with regard to strokes, TIAs, heart failure, survival and quality of life when we operate on a patient. This is a paper that we contributed based on the STS database showing that in patients with coronary artery disease, I think this is very important as well, atrial fibrillation, even after being controlled for comorbidities, is a predictor for worse outcome following CABG with mortality, resource utilization, stroke rate, and any reoperation. There's another paper to show that atrial fibrillation is harmful, and basically when we are equipped with all this information, there are other papers, but we don't have time and to discuss all this. The question is, what do we do in the operating room? And what do we do in the operating room is based on, as I said, our experience, but also on our colleague cardiologists and their referral to patients to the operating room. Sometimes with kind of ridiculous comments such as this patient is having left atrium of 6 centimeters or atrial fibrillation 3 years or longer, so don't even bother to do anything, which is not based on any evidence. But when you know that atrial fibrillation has some degree of impact, then the question is why, when we look at the STS database, only 39% of patients undergoing surgery while with significant atrial fibrillation having any kind of ablation. I'm not talking about the appropriate ablation. And if we move ahead, it's actually worse in patients with AVR, CABG. Mitral valve surgery, we're doing pretty well, about 60%. CABG AVR is the same as CABG or AVR. And CABG mitral valve and others are doing slightly better. So one question is, how come that we don't choose to do a surgical ablation? If it's complexity or patient risk factors, so how come CABG and mitral valve, which may be our most difficult and risky group of patients, especially those with functional MR, having about 50% ablated as opposed to 30% ablated in the AVR group? The answer is probably if we are already in the left atrium, we feel more comfortable not to extend surgery beyond what it requires as opposed and basically perform surgical ablation. But going back to your own stroke, I mean, if we have significant TR, we'll never leave it alone. if it requires to be treated. So part of the problem we have as surgeons is that we are not really convinced that atrial fibrillation has any merit in the patient outcome and should be addressed. And this comes to the definition of two different surgeons. Surgeons that try to survive the operation and surgeons that try to have their patients survive long term. I think this is also very, very important. We have to move away from that stages of patient survive the operation, therefore I'm a great surgeon. My patient survived for 30 days and I'm even greater. And patients that survive long term, which is basically why we are here. So together with Atrial, actually, a company that got the first device approved for concomitant procedure in the US, we are actually in the middle of a campaign to educate surgeons and cardiologists about the significance of atrial fibrillation, and we start to see some progress in at least in the implementation of the procedure. This is a survey that was done by the AATS to ask the question why surgeons don't perform the MACE procedure. Add too much complexity to the primary procedure, pump time, and not willing to introduce any risk to the primary procedure. All not based on evidence, it's all misconception. So we have published and others published simple questions and answers. This is a Cox-Mace procedure with aortic valve and coronary artery disease. The conclusion is that the addition of the MACE 3 procedure was not associated with significant risk and significantly improved patient outcome. As you can see here, this is a propensity match, and you can see the outcome, except for atrial fibrillation during stay, atrial fibrillation and discharge, and length of stay, which is reasonable as compared to other places without the MACE procedure, were significantly longer with the MACE procedure group, but there was no other really bad things that happened, despite the fact that we added a full MACE procedure to CABG and AVR, which includes opening of the right and the left atrium and so on and so forth. Long-term survival was the same in the propensity match group between the AVR CABG without the MACE versus the ones that had combined, which suggests that we may be improving patient survival. Reported result may not be duplicated by non-experienced surgeons or non-experienced centers, and as we can see here, that there are multiple publications from all over the world showing that there are a significant improvement in aspects of longevity, quality of life, degree of increase of the size and the mitral tricuspid regurgitation over time. This is a paper from the Mayo Clinic. And obviously, stroke rate is a big addition with significant reduced in stroke rate and valve-related thromboembolic events. And recently, a paper from Northwestern showed that treated AF versus untreated AF had longer survival or better survival in matched groups as well. So, what do we know from our own paper, from our own center? Not just to give you an idea, over the past 10 years we performed over 1,200 MACE procedures, but more importantly, we created a prospective registry that has about 3,000 variables per patient that are being collected in a very meticulous way, but a big group of people. And we can draw a lot of conclusions and important data ongoing with this type of registry. So success rate over time is based on the HRS guidelines, reporting 83% of the patients for multiple surgeons are off antiarrhythmic drugs and in stable sinus rhythm, not by a strip of an EKG, but also monitoring at 24 months and long-term monitoring. Those patients that agree to have 1 week auto monitoring is even slightly better, 89%, but maybe there is a selection here. Stroke rate and freedom from stroke is pretty impressive for this subgroup of patients, as you can see here, with a relatively long follow-up. This is in lieu of the fact that about 75% of the patients are off anticoagulation. And as you can see, 16% of the group of the patients are on anticoagulation for a reason. Either they are in recurrence AF or they have other issues like a mechanical valve or history of thromboembolic event and so on and so forth. 9% of the patients are still on anticoagulation without good reason. More importantly, the survival rate of the patients, when you look at the mitral valve that came in sinus rhythm versus those that had a MACE procedure, we basically have the same survival rate over time, and we compare the group of patients with MACE procedure versus those that were left alone with AF. Even after, so you can see that the survival rate is significantly better with the group that had the MACE procedure. But even after adjusting all this, there is some degree of selection bias over here because the patients with AF obviously were maybe slightly sicker. What about the society consensus? We just showed that that the American Heart recommendation saw some level C evidence for chronic persistent atrial fibrillation, which I don't even know what it is because it's not the definition by the HRS guidelines. But we have some other guidelines to basically support that all patients with documented AF should be operated on if it doesn't add significant risk to the procedure. And this is the Heart Rhythm Society recent guidelines. But more importantly, when you look at the guidelines that were put together by ISMIX, that I was privileged to chair, show that based on some RCTs and the definition for level A evidence, and I think Dr. Banai made a good point, and I will readdress it in the debate. Two prospective randomized studies are sufficient to be level A evidence, which we can argue if this is enough. But here you have quite a few RCTs in this field by surgeons, and basically some of the conclusions we do based on this for these guidelines are level A evidence and class 1 level A evidence for increase sinus rhythm, 2A and level A to improve ejection fraction and exercise tolerance, and 2A level B to reduce the risk of stroke and thromboembolic event. Part of the problems we have with the surgical literature is that it's really hard to make sense with a lot of those small serious and inaccuracy in reporting according to guidelines, but we're working hard to fix that. So what about increased left atrial? So we run a study in our own data looking into a cutoff size of 5.5 centimeter in diameter. We can argue whether this is enough, but we have some data with volumes as well. I just don't have time to bring it here. But as you can see here, there is not much difference between those that are large left atrium versus sorry about that, and small left atrium with regard to 24 and 1 year success rate. Off medication, as you can see, about 3/4 of the patients, 2 years are off medication by multiple surgeons, 2 years, even when the atrium is over 5.5 centimeter. More importantly, freedom from embolic stroke is identical for both group, which means that there is some merit also from that aspect of the procedure. And as you can see, predicted probability of failure at 1 year was 43% greater for each increase in 1 centimeter of the left atrial size in the univariate model. But multivariate model showed that the best predictors for failure are not the atrial size, are the duration of AFib, which suggests remodeling, and the number of concomitant surgical procedures, which suggests that other issues are important. Left atrial size was not an important predictor. Within the large left atrial size group, only duration of AFib was found to be an independent predictor of failure. So it's not just the left atrial size. Probably the duration of AFib, as we see now with prospective studies, is more important in the decision making. And this is a spline curve that shows the success rate over time with and without medication, where the dashed line is without medication, slightly higher failure rate. But just to look at it, even if the atrium is 10 centimeters at 1 year off medication, you are still standing somewhere above 60% success rate, which is better than zero. When we look at the slope of this spine curve, there are two critical sizes. One is the 5.5 centimeter for any type of success rate, and the other one is around the 7.5 centimeter for both sides, where you start to see acceleration in deterioration of success rate. But still, size of the left atrium as itself should not be an issue, and none of these patients were treated for LA reduction procedure. Over 75, very good follow-up and very good survival rate. And now we're getting to the most important point, which is the surgeon experience. So we did look at it in a very detailed way, and we look at surgeon experience in lieu of the patient and the complexity of the patient. And what we found that basically, generally speaking, no ablation and surgical ablation, there was no significant difference in perioperative outcome by the STS definition for valve disease, CABG, and MACE procedure. Perioperative outcome was, although that we don't have too many patients with over 3 or 4 or 3 plus comorbidities, that we had a score that I don't have time to go through it, but 10 different variables that created that score shows that actually the perioperative outcome are quite the same. And what we found in this study, and I'll show you spine curve in a second, that with surgeon experience predicted surgical ablation with 6% greater odds for every 10 cases. The group of surgeons with over 50 ablation cases performed 57% of their operated patients with AF. They performed some type of surgical ablation versus 22% only for those with less than 50 cases. And therefore, the most experienced surgeon's decision to perform surgical ablation was less influenced by comorbidity factor, as you can see here. And this is a kind of an arrogant spine curve showing my experience as opposed to the rest of the group. But I think it is worth showing, despite the arrogancy, just to show that even if you have quite a few comorbidities, you still operate on many of those patients with acceptable outcomes. Meaning surgical experience in AF, like any surgical procedure, should be considered, and referral patterns should be also considered, because it's a really important issue. Unadjusted and adjusted 5-year survival was shown to be better after ablation as well. This is a paper that's going to be published in December in Journal of Thoracic Cardiovascular, looking to different high-risk group, intermediate group, and so on and so forth, based on the European data. Euroscore, showing that success rate is the same across risk group, survival is the same across risk group. And a recent paper from Portugal showing that for mitral valve patients and AF versus no AF, there is a significant difference in survival following the procedure. Prediction of sinus rhythm. This is a new model that we developed. This is the first model to look into an outcome of a procedure, which suggests that maybe we need it also for mitral valve, based on Woody's remarks from earlier. And basically you click the numbers, there is a calculator, and you have a predicted probability. This is not the outcome, this is the predicted probability. We are validating the paper now, the data, make sure that it can be used across the board with different type of variables that were put in there. Thank you.